Greetings, we're in for a treat. I'm Bruce Ovbiagele, the editor-in-chief of JAHA, and along with Katherine Wu, senior editor of JAHA, would like to welcome you all to this special episode of our AHA with JAHA podcast entitled Distinguished Hearts and Minds Roundtable. This annual forum features a conversation with the American Heart Association distinguished scientists for that year. It is intended to highlight the work and the perspectives of these brilliant laureates with the goal of informing and inspiring other scientists, strategists, and society about advances in cardiovascular science and the journey of successful academic role models. Indeed, as part of this, over the course of this podcast, we will get to know about what these eminent scientists have done, learn about what they have learned, and hear about how they see the future of research in their various fields. And so as part of this forum, we will have the different guests answer general questions and also answer specific questions. Our eminent guests today are Dr. Robert Bono. He is the Goldberg Distinguished Professor of Cardiology at the Northwestern Feinberg School of Medicine. He's editor-in-chief of JAMA Cardiology and an editor of Brownwell's Heart Disease, a textbook of cardiovascular medicine. Welcome, Bob.
Thank you, Bruce.
Next, we have Dr. Pedro Del Nido, who is Chairman, Department of Cardiac Surgery, and William Ladd Professor of Child Surgery at the Harvard Medical School. Welcome, Pedro.
Thank you.
Next, we have Dr. Deborah Moser, who is Professor at the University of Tennessee and Professor Alinda C. Gill Chair of Cardiovascular Nursing Emeritus at the University of Kentucky. She is the Director of the Research and Interventions Cardiovascular Health Heart Program and editor of the Journal of Cardiovascular Nursing. Welcome, Deborah.
Thank you.
Next, we have Dr. Jane Neuberger, who is the Commonwealth Professor of Pediatrics at the Harvard Medical School and Associate Cardiologist-in-Chief for Academic Affairs at Boston Children's Hospital. She's a member of the National Academy of Medicine. Welcome, Jane.
Thank you so much.
Next, we have Dr. Jiang He. He is the S. Roger and Caroline P. Hircho Chair in Cardiac Research and Chair of the Department of Epidemiology at the O'Donnell School of Public Health at UT Southwestern in Dallas. He's a member of the National Academy of Medicine. Welcome, Jack. And next, we have Dr. Stephen Young. Dr. Young is Professor of Medicine and Human Genetics at the University of California, Los Angeles. He's a member of the National Academy of Sciences. Welcome, Stephen.
Thank you.
So we're honored to have all of these eminent researchers at this table at once. And I'd like to extend our heartiest, no pun intended, congratulations to all the AHA 2024 distinguished scientists for this well-deserved recognition. We will alternate between general questions for our scientists and then also specific questions pertaining to their respective fields. So at this juncture, I'd like to turn it over to my co-moderator, Dr. Katherine Wu, to ask of our guest a general question. Over to you, Kathy.
Thanks, Bruce, and welcome to all our distinguished laureates. Thank you for sharing your insights with us today. So our first general question to the group will be, what does being named an AHA Distinguished Scientist mean to you? And how has your involvement in AHA influenced your career trajectory? So we will start off with Dr. Bono.
Well, Kathy, first of all, just state the obvious. I'm in awe of all of the wonderful accomplishments of the other people around this table and humbled to be part of this. It means an awful lot to be recognized by your peers. And it goes without saying that it's a wonderful feeling of accomplishment, but also humbled because research is a team effort, and anything I may have accomplished would not have been possible without the terrific support from very talented young people and older people who guided me along the way. My involvement with the AHA was kind of unique because I was initially a researcher at the intramural branch of the NHLBI, so I had federal funding. So my involvement with AHA was publishing in circulation, which was really prestigious at that time, because there were very few journals, and also coming to this meeting and presenting my science. And through that mechanism, meeting other people, networking, getting involved in council activities and committees, which allows you to really refine your science, and also find networking opportunities beyond the borders of your own institution. And so that's how I started. But then once I left the NIH and went into an academic environment at Northwestern, I realized how important the funding would be, the mechanisms for getting young people involved in their research.
Thank you so much, Dr. Bono. We'll move on now to Dr. Del Nido.
Thank you, Katherine. Well, following up on what Bob said, AHA for a surgeon often means seed funding for your initial work. And certainly for me, that was the case. I was a brand new faculty and had a lot of ideas, a lot of ambitions, a lot of work that I wanted to do. But obtaining funding was very challenging without a track record and always working under a mentor. Really demonstrating independence is going to be the biggest challenge. I got my first grant here in Chicago, and so I think it's befitting that this award I receive in Chicago. And so I'm very proud of that. I think it is a pathway that many surgeons, many young surgeons have taken in the past and have led to very, very successful careers in academic surgery. And it's spawned from here. And I have to also say that the meeting represents a forum for academic surgeons to get together and discuss ideas above and beyond the technical aspects of what we do, and look at diseases and really share ideas with our cardiology colleagues on how we approach and how we think about the long-term management of disease. So I think it's a unique forum, and I've been a member since I can remember. And I'm very proud, as I said, of the fact that I got my start by the funding from AHA.
Thank you so much. Dr. Moser?
So, of course, I'm delighted, and I'm really delighted to represent nurses. I'm a cardiovascular nurse scientist, and nurses don't often win this award, and so people have just been so wonderful to me about, being a representative for nurses, and it's of course delightful for myself, but also for all nurses and people that I've mentored. I have really thought of the AHA as my professional home since I was way younger and started in a master's program. And my mentor, Dr. Kathleen Dracup, had me always, doing abstracts and presenting locally and then regionally and finally to the to the AHA. And so for many, many years, I actually have always submitted and presented every year since then. And I actually received my first extramural funding from the AHA to really start off on a great career that has given me the opportunity to work with so many wonderful students and mentees. So it has been delightful and a great career and a great place to have a professional home.
Yeah, really wonderful stories here, very kind of diverse perspectives, and brings a lot and emphasizes really the what AHA can bring and can really change the trajectory of a career. So we'll move on to Dr. Newberger.
Right. As a pediatric cardiologist, this has been also a tremendous home for my community. We meet each other from all around the country and internationally in these sessions. I presented my first abstract at the American Heart Association, and I also have not missed a meeting since that time. I especially appreciate the guidelines that the American Heart Association puts out, which is an enormous effort. I mean, and also the journals, and spent probably 12 years as a senior editor of Circulation when it was in Boston. And of course, JAHA is wonderful. So thank you.
Thank you so much. Dr. He?
Yeah, it's truly a great honor to be recognized as one of the AHA distinguished scientists. This award really highlights the importance of our work in global hypertension prevention and control. Really, American Heart Association has played a critical role in my career development. I remember during my PhD studying, AHA funded my dissertation research, then become a junior faculty, and AHA gave me first research grant. So really, AHA really helped me develop my career. So.
Wonderful. We'll end with Dr. Young.
Yeah, it's a huge honor for me to get this award. The American Heart Association has been so important in my career. As a young faculty member, they supported a series of grant and aids which were important for getting my career off the ground. And more than that, I think they were very important for me to learn how to write persuasively, both in grant applications and in manuscripts, and that was crucial for me. And but not just that. I mean, I participated for many years in the peer review activities of the American Heart Association, which really was an eye-opening experience and allowed me to sort of hone my academic skills. Again, for many years, I presented abstracts here at the meeting and allowed me to learn how to present our ideas and our hypotheses. But with this award, I would just underscore what others have said, is that my scientific career has depended so much on my trainees and my colleagues. I could never have done this by myself. You know, many of the ideas, the day-to-day honing of hypotheses, that all couldn't have been done without my colleagues, and so I'm very grateful for that.
No, thank you all for that, and you can hear the profound sense of humility in all of our distinguished scientists, and just recognizing, as people mentioned, the AHA as a home. And that was a place of nurturing, so to speak, but the kind of home that you actually don't grow up and leave, it seems like, because people keep on being involved in it. But just hearing about being involved in journals, being involved in receiving grants, being involved in the guidelines, I think just speaks to the value of AHA's contribution to developing eminent scientists like this. So we'll now move to our more specific questions. I'm going to start off with Pedro, if I may. And Pedro, you've been a pioneer in surgical innovation. Your research in particular focuses on innovations in patients with single ventricle physiology. Have we reached a plateau in survival benefit? And what technical advances could further enhance longevity?
Oh, hardly. We have so much work to do. The one thing about congenital is, our patients evolve with us. In other words, the problems that we face today are going to be very different than the problems we're going to face 5 years from now, 10 years from now, because our patients are aging, partly, in great part, because of the successes that we've been able to get them to survive the early procedures, but also in part because they have acquired diseases on top of the congenital problems. So our field continues to evolve. The single ventricle I took on as a challenge because we could see very early on that the long-term outcomes of children that are palliated with single ventricle was not going to be good. And so we needed to start searching for a better solution. And that required a better understanding of the mechanism. So why does this single ventricle develop? Are there things that we can do? Are there areas, even if it's a minuscule component of the disease, is there an area that we can focus on that we can actually make a difference? And so that's what started the idea. We looked into mechanisms of ventricular growth, what induces growth, particularly in the fetal stage. what limits and restricts growth, and we came across this concept that fluid forces are really critical. And anything that impedes the impact of the fluid forces on a structure impacts its ability to truly grow physiologically. So that led us to understand that there is abnormalities, particularly in the endocardial development, that result in lack of chamber growth and associated other problems with valvular heart disease. And we've done a lot of work looking at mechanisms, but then we needed to develop therapies. And so we as surgeons, we took the simplistic approach. What if we take the tissue out? What happens? And fortunately, we had colleagues in the cardiology field who supported us in this effort. And actually, they were the ones who truly pioneered this because they intervened in the fetus, opening up valves, heart valves in the fetus to see if that hemodynamic change improved the ventricular growth. And it gave us the idea that perhaps things that are mechanical could actually make a difference. And that spawned the whole area. Now it's become part of a standard of care for many of these children. But early on, that was the impetus for us.
Amazing.
There's a question for Deborah. So how have the biobehavioral self-care interventions you've developed impacted cardiovascular outcomes in rural populations?
I think that we have made some great inroads into improving cardiovascular outcomes in rural populations, which actually have the worst, have horrible cardiovascular disease and risk factor disparities that seem to be sort of unrelenting. And there are a lot of political factors that can play into things, providing more money, less money, that make it frustrating in that area. But ultimately, the goal of these sort of interventions is to really empower people who live in under-resourced areas, who, can't make it to a cardiologist. There isn't one for miles and miles, 3-hour drive, who can't make it to a hospital sometimes. There are becoming less and less hospitals who, in bad weather can't even make it out of their house, who, are really impacted by, floods and incredible snows, their infrastructure is very poor at times. And if you can, with these sorts of interventions, empower people to understand how to take care of themselves, it seems so obvious to all of us. Well, of course, we take care of ourselves, but in fact, it's incredibly hard at times to understand what you need to do to get the motivation to do it, and then to really overcome the barriers, your environmental barriers to doing it. And so our interventions are individual, but also focused on the populations and the problems in the population. And that's why they've had an impact and have been, interestingly, picked up by, for example, the fire department in one of the towns that we developed our program and used it as part of their yearly training and their yearly work that firefighters have to do. And at senior centers, they, worked at our program. So these sort of programs have difficulty ultimately being funded. But if you take the approach that we have to empowering individuals, empowering their healthcare providers and the community, you have a much greater impact. And I think that's where we've really gone with these interventions and why they've really had an impact in reducing cardiovascular disease, at least risk factor disparities in a lot of areas of Appalachia where we work.
No, thank you so much for that, Deborah. I think that kind of real-world impact is always very important, and there's nothing like having that kind of uptake into the community of science that's done. So thank you for that. Next question is for Jane. Jane, you have your seminal work has been transformative in terms of helping us to understand Kawasaki disease. We're hoping to learn from you what your experience with the diagnosis and management of Kawasaki disease has done to inform therapies for the multi-system inflammatory syndrome in children associated with COVID-19, or could you say MISC? And it's a two-part question. Are we any closer to determining the etiology of Kawasaki disease? And if not, why?
So when COVID began, when the pandemic began in December of 2019, we thought children were spared. A relatively mild disease, but by the spring of 2020, people described this hyperinflammatory acute shock syndrome in children that looked like atypical Kawasaki disease or toxic shock. And those children had rash, red eyes, swollen hands and feet, and even expert clinicians sometimes couldn't tell the two diseases apart. In fact, Miss C was sometimes called Kawa-COVID. We were very lucky because we had protocols for treatment of Kawasaki disease and Kawasaki shock syndrome and research teams, so we were able to flip those systems and apply them to individuals with Miss C. And in fact, the same treatments are given to Miss C as Kawasaki disease, and many of the networks that kept data were able to accommodate data collection in this new group. Your second question is interesting. I mean, we know that Miss C is caused by SARS-CoV-2, but we still, despite decades of research and also controversy, do not know of a single cause of Kawasaki disease. There's a lot of evidence that it is triggered by infections. We know that because of the seasonality and because it tracks with childhood viral epidemics, and also because during the pandemic, when people had precautions and children didn't go to school or they wore masks, the Kawasaki incidence plummeted. Of course, Kawasaki is a rare disease, and there are genetic variants, mostly related to the immune system, that seem to determine your predilection to Kawasaki and also your likelihood of developing coronary aneurysms. And so I think currently most people believe that this is a post-infectious hyperinflammatory disease that people with certain genetic predispositions might be subject to, but it's been very hard to pin it on any one cause.
Thank you.
Very fascinating. It really highlights this genetic environment, triggers and combinations that really we're learning more and more about.
Right.
All types of new infectious diseases. So the next question is for Jung. So in 2017, you showed that a community health worker-led multi-component intervention for low-income patients with uncontrolled hypertension in Argentina resulted in blood pressure control at 13 months, better blood pressure control at 18 months compared to usual care. So has the intervention now been implemented and scaled up anywhere in Argentina? And if not, what have the barriers been?
Thank you. In the Argentina hypertension control project, we demonstrated a multi-phased, team-based care model significantly reduce blood pressure and improve hypertension control among low-income patients who receive their health care from a national public health care system. The program includes primary care provider training on protocol-based treatment, community health worker leader intervention, health coach on lifestyle change and adherence to medication, as well as training participants on home blood pressure monitor. So since we published our study, my core principal investigator become the Ministry of Health in Argentina. So under under his leadership, the Ministry of Health scaled up the program in the entire national public health care system, include training physicians on the clinical guideline and the protocol-based treatment, training community health workers on chronic disease management, and giving the blood pressure monitor to all the patients for free. So, and this program also scaled up in larger many other low-income countries and the low-income populations. For example, we are doing a study with FQHC clinics in Louisiana and Mississippi in low-income population. So we implement this program. We training providers on intensive blood pressure control based on protocol, and we training community health workers on health coach, as well as give patients a free blood pressure monitor. Our program really show a great reduction in blood pressure and improve hypertension control in low-income population. We presented this study last year at the American Heart Association late breaker clinical trial session. So I hope our program will be scaled up widely in low-income populations.
No, thanks, Jiang, for that, and congratulations. That was a very, very important study, and I see parallels between your work and Deborah's work, obviously, in trying to reach underserved populations. It seems as if part of the secret is making sure that one of your investigators has prospects to be the health minister, so that you can roll things out. No, but congratulations on that. So next question is for Stephen. Stephen, you have done some superb work when it comes to lipid science. And so I wanted to ask you about your insights into what we've gained from solving the GPI HBP1 LPL complex structure, and can it be used to improve the diagnosis of lipid disorders other than chylomicronemia?
Okay, so you're right. Since the time of my cardiology fellowship, I've worked on lipid metabolism. And one of the things that we've worked on for the past 10 or 15 years is intravascular triglyceride metabolism by lipoprotein lipase, LPL. LPL had been studied since the 1950s intensively. And 4 decades later, I think most people thought that all of the problems were solved. But there was, and that's when we were fortunate enough to enter the field. And one of the things that we recognized is there was an outstanding mystery. It had been a mystery for so long that people had forgotten it was a mystery. And that was, how does lipoprotein lipase, which is made by myocytes and adipocytes, reach its site of action in the capillary lumen? So we were fortunate enough to identify an endothelial cell transporter that picked up the lipoprotein lipase, moved it across capillaries to the luminal surface of capillaries, where LPL has to be in order to hydrolyze triglycerides in the plasma. So one of the things that we learned early on is that not only was this protein, endothelial cell protein, a transporter, it also stabilized the structure of lipoprotein lipase. Lipoprotein lipase is inherently unstable. On a purified preparation of LPL loses its activity within minutes. But this endothelial cell protein stabilized the structure of LPL. So for many years, a key goal in the field was to solve the structure of LPL. And everyone failed. And the reason that they failed was that you can't crystallize an unstable protein. But what we did is we were successful with Michael Plough and Gabriel Bahrain in solving the structure of the GPI-LPL complex because it was stable. And what we learned from that is, from the structure, was obviously how these two proteins interact. And they interact by hydrophobic interactions along a fairly large interface. And what we found, we'd identified a lot of mutations in both proteins that cause severe hypertriglyceridemia or chylomicronemia, and many of those mutations lie in the interface, a hydrophobic interface between these two proteins. So we identified GPI mutations that prevent LPL binding and LPL mutations that prevent GPI binding. And those cause severe disease. It's lifelong chylomicronemia. But then what we also found is that occasionally there were patients who developed severe chylomicronemia without any of these mutations. And what we found in those patients is autoantibodies against GPI-HBP1. And those have the same effect. They block LPL binding, block LPL transport to the capillary lumen. And whether you have a germline mutation or the autoantibodies, the LPL is stranded in the subendothelial spaces and never gets to where it needs to be, which is the capillary lumen.
Fascinating, very fascinating structure, function, correlations. So the next question is for Bob. So despite tremendous progress, the timing of valvular intervention to optimize long-term outcomes remains a significant clinical dilemma. So what do you see as the next frontier and how imaging can close this persistent gap?
Well, thanks, Kathy. Yeah, we have a lot of hurdles and lots of challenges ahead. It is interesting if we think about the 100th anniversary of the AHA, our centennial, and we look back in 1924 and, 1924, what was available then and what's changed since then? Imagine 100 years from now, people looking back and talking about how crude we were in our understanding of the pathophysiology of valvular disease and our treatments, kind of crude as well. Although they've advanced rapidly in very exciting ways. When I was a student, my first patient with aortic stenosis, in my cardiology rotation was a patient with aortic stenosis, so I've been interested in this ever since. And a lot of the imaging has gone on to look at how severe the stenosis is, how severe the regurgitation might be in patients who have regurgitant lesions. And we've gone a long way. We realize now that for aortic stenosis, this is not passive wear and tear. It's an inflammatory proliferative lesion, and therefore there could be drug targets along the way. But there's been so much focus on that, there's been less focus on the myocardium. And although we do measure left ventricular function, it's in our guidelines and when to intervene, those are very crude measurements, left ventricular ejection fraction and volume. What's going on in the myocardium? And so some of the newer, exciting, and hopefully forward-thinking movements would be to try to understand what is going on with hypertrophy. And when do patients start developing interstitial fibrosis and maybe frank replacement fibrosis, which could represent perhaps microvascular ischemia. And so if we're talking about drug targets, maybe the targets are not only what's going on with the valve, but also what could be done to protect the myocardium. But that's just the imaging side of this. I mean, there's so many other ways of marrying the images with other things that we should be doing and not doing well yet. Biomarkers. Genomics. We do know, some very simple genetic differences are between men and women. For aortic valve disease, women develop a little more hypertrophy, less calcification of the valve, more fibrotic changes on the valve. So there's clearly some genetic components there. And we already have genetic polygenic risk scores for who is going to progress with aortic stenosis. So I think in the future, perhaps what we're going to need is something like artificial intelligence to take our imaging characteristics, the genomics, the proteomics, the biomarkers, and begin to become a little more individualized in our management of patients. And then we're talking too about multimodality imaging. When do we need more than just an echocardiogram? When do we need a CT? When do we need an MRI? How do we begin to understand, which patients need a little more intensive workup and when to intervene earlier? So I think the future is bright. There's lots of research opportunities for young people to get involved with this field. It's been driven by the, all the technology we have now with transcatheter approaches, but that's driven a lot of really interesting imaging finding as well to identify who the patients might be, who would be the best candidates for our interventions.
Superb. Thank you. Thank you both for that. Our next question is going to be a general question of our esteemed guests, and it's the question that really speaks to if you were ruler of your scientific universe. You're all leaders and accomplished scientists, but this question is really about what you would do to really try and improve how science is done in your field. Is there one approach or policy that you think could really be transformative in your neck of the woods, so to speak? And so we'll start off with Dr. Moser.
There's so many things. So one of the issues with science that nurses conduct is that we sometimes, even though we have physician colleagues, we have multidisciplinary teams, there still is this difficulty working in practice with physicians who are in practice, because nurses, except for advanced practice nurses, often don't have their own practices. If they're working in a hospital, they're actually, they're hired by the hospital. And even though we see physicians and nurses working, really well together, in fact, when it comes to implementing a lot of interventions that nurses develop, it's more difficult because we haven't developed really integrated relationships. So, we talk to each other, we listen to each other, we do, we inform what each other does, but ultimately, because of the big structures that are in hospitals or in clinics, or, because of the business side, it's really difficult to integrate a lot of nursing interventions that are easy to implement, that are actually low cost, and that would be perfect in the clinic or in the, the free clinic where, we do work, or in, hospitals, if there was just really true interdisciplinary collaboration that guided policies in implementing interventions. Another thing that's important is to have more mechanistic studies for these sorts of biobehavioral interventions. So it's a lot of times people come to these interventions, they're not theory driven, they sort of often don't understand the mechanisms. They just go, hey, this looks like a good idea. Let's just start calling people up and see what happens. And a lot of interventions that are not theory-based, that haven't built on other interventions, the success or failure of other interventions, fail just not because, they may not be a good idea, but because people haven't understood the reasons why you do the various things you do in these interventions. They're complex a lot of times, very complex. Some parts work, some parts don't. And if you don't understand the mechanisms for each part, you never understand why they work. And there are certain groups of individuals for whom interventions work better, and you need to discover that too. So, who benefits best from one approach versus another approach, and to consider that, of course, we need precision medicine in these sorts of biobehavioral interventions too. I think those things, changing some of that would go a long way toward improving the science in that area.
Well, thank you, Deborah. Let me just follow up with that. What's the best approach? Because especially the first one, in terms of interdisciplinary collaboration, that seems like low-hanging fruit. Could the AHA issue a policy guidance to try and help people to, how could one, and even with the latter as well, in terms of really being able to understand the different facets of an intervention, how should one? Well,
part of I think the solution, and some of the things that we have done where we've partnered with, for example, a clinic in Appalachia for indigent patients, and there actually aren't physicians there. They're run by nurses and community health workers. And so they were interested in adopting this the intervention. Didn't think it was, people think it's too time consuming. It's all about teaching. It's all about, oh my God, I don't talk about stuff. Really sort of forcing people to study interventions that are integrated into the system and really understood and used by everybody who uses the system. So the physicians, the nurses, the pharmacists, those are, some of the best types of interventions, but they're really kind of stranded out there. They've shown to be effective, but they're in this one great hospital or, two great hospitals. And it's really not, we haven't a great environment for getting these interventions, you know, their uptake. It's not like a drug that, and it has to do with money, it has to do with, you know, old resistance about how, you know, we all have interplay. But yeah, policies that say for this grant, if you want to do it, here's what you have to do. If you want to get it, here's what you have to do.
Still goes back to the Minister of Health issue.
Yes, I was loving that, hearing that.
Jane, if you were ruler of your scientific universe.
Oh, I guess my blue sky would be in the informatics domain, well, informatics plus, that if we could have, we deal with rare diseases, if we could have an infrastructure that put in our clinical data, our imaging data, our sera, our DNA, and allowed us to then do intervention trials or mechanistic studies reaching into that database, I think progress would happen a lot faster.
Makes a lot of sense. Thank you for that. Jiang, you already have the Minister of Health in your pocket. What else do you need? What else do you need?
Yeah, so my field is epidemiology and public health. So traditionally, we have focused on, you know, observational epidemiology studying and, you know, the risk factor epidemiology. Observational studying, such as Framingham heart studying, really made a great contribution to our understanding risk factors for cardiovascular disease. And also, observation studying contributed to identify genetic multi-omic, you know, biomarkers for cardiovascular disease, right? But recently, you know, more epidemiologists have realized observational studying and the etiology research should not be the only purpose for epidemiology, right? So that because the final goal of epidemiology is really improve the population health, you know, prevention and control disease in community. So, so we need to make a great effort to develop novel interventions and implement those interventions in community to improve population health. So I really think the translational research and the implementation science really provide a great opportunity for the future epidemiology research.
No, I couldn't agree more. No, thank you for that. Stephen?
Okay, so I have a couple of ideas. One, just for the American Heart Association, I'm a real believer in investigator-initiated research, and so I think that what I would recommend is that the AHA go back to earlier funding mechanisms of just grant and aids and postdoctoral fellowships and not do the very large programmatic grants. That's one thing. For the other thing that I think needs to be addressed is that now in universities, scientists are burdened by an enormous amount of administrative tasks. And you can see that scientists are now spending a lot of their time responding to emails every day on administrative tasks. And, you know, for example, UCLA doesn't have great electron microscopes. So we need to, recently I needed to get some electron micrographs taken at the University of Oregon. I am now 3 months into, with hundreds of emails, involving the Vice Chancellor's office and legal departments, and it's just silly. I mean, it's probably increased the costs of getting these electron micrographs done by 50-fold. And what I think that the NIH needs to do is to work with universities to cut all the red tape for scientists. We're being taken away from training, taken away from doing great experiments, and I think that the NIH needs to work with universities to solve this problem. I think that I'm not exactly sure how that's going to be done, but there's been in universities an enormous growth of administration with not a lot of growth of science, and that just continues to grow. And I think that the NIH needs to work with universities to solve that problem.
Thanks, Stephen. You had everybody's heads nodding. Bob?
Well, I've learned a lot just from this few minutes of conversation with my colleagues, because I think we're talking about some policy issues that kind of fits in my space too. First of all, we do have, in my institution, which is kind of an ivory tower academic institution, a very well-run multidisciplinary team, which includes nurses, really important drivers of the process, and cardiologists, both interventional and imaging, and some of the imaging is done by radiologists, and we have surgeons. So we actually have a pretty coordinated, integrated process. And that's the way it's supposed to be. But that's not the way it happens in many places, right. And especially in smaller community situations and environments where we're trying to get access to these treatments and imaging and so forth to some underserved populations. Okay, how well do the multidisciplinary approach actually work in that environment? Which then gets into the bigger picture, which really gets back to what Deborah was talking about, and that is in the underrepresented areas of the country, access to some of these technologies, and simple technologies, even imaging. And it doesn't have to be a regional issue. It doesn't have to be rural or urban. You could go to Chicago and look at the different zip codes. And we actually have data from Philadelphia, zip code areas, looking at who is being identified with aortic stenosis, who's being referred to the center, who's being followed, who may have appropriate interventions. And so I think we have a real issue here in access to care. And it's not just the cardiologists and the imaging people, it's it's a primary care physician. Who's hearing the murmur? Do these patients actually see physicians or other healthcare providers who can determine when they may have issues here that could be evaluated? Otherwise, we wind up with some other forms of disparity where we have patients coming in with heart failure, which might have been diagnosed earlier as perhaps a valve condition that could have been treated and appropriately and so forth. And so it gets into the bigger picture, which kind of gets back to where we first started talking about how the AHA broadens one's knowledge of what's going on. Because, as I started in my earlier career, getting more involved with the AHA allowed me to see the broader picture of where my own research might fit in, and the issues of, disparities, the issues of rural versus urban issues are real challenges for us if we really want to move the ball forward for our patients.
Fully agree. No, thank you, Bob. Pedro.
Well, I'm in a peculiar field in the sense that, as Jane mentioned, all we deal with is rare diseases. Every child has their own rare disease, even though we lump them into categories. They're all a little bit different. The care that's provided is quite variable. And instead of the technology being the problem, it's usually the expertise or the experience of the practitioner in the surgical field is the limiter. And so someone who's been out there 20 years and has seen 100 of these can do it much better than someone who sees it once every 5 years. And everybody understands that, but I think the question is, how do we solve that problem? So we embarked on a project to try to use imaging as a tool for not just modeling what's going on anatomically or physiologically, but as a tool for simulation. And if you can go from the patient-specific imaging to a patient-specific simulation, and there's a lot of technology that has to go into that. And we've incorporated a lot of very, very smart engineers who know a lot of flow dynamics from the aerospace field, bringing it into our problems. And then we can actually simulate the problems of the child, simulate the therapy long before the surgeon walks into the operating room.
Excellent.
And that democratizes the field. It's pie in the sky. I recognize this. You were nowhere near, but we've made some very good inroads. And what's happened is that all of a sudden now the engineering community has gotten excited about it, and the artificial intelligence community has gotten excited about it because that's an application for them that they have not tapped.
Absolutely.
And so I think we're at a time when things are going to change very rapidly. And so that if you happen to be in a rural area but you need access to some very specialized care, it's available because it comes through the wires. It doesn't necessarily, you don't have to have an individual with a lot of expertise transported there or vice versa, which is the more common scenario. So that's my dream, that's my goal, and that's what we're working on.
Lovely. Oh, thank you. Kathy?
Okay, so we're going to move on to specific questions for each in the group, and then we're going to start with Jane. So you pioneered the evaluation of neurological outcomes in patients with severe congenital heart disease. So what would you tell patients of a child being discharged after successful palliative surgery about long-term outcomes in this regard?
So this is something we do every day. For a child, usually a baby, or a young infant who's just had surgery for palliation, which is usually single ventricle, we explain that neurodevelopmental morbidities are probably the most common and among the most distressing sequelae of congenital heart disease. I review the etiology, so the same genes that go into how the heart is formed are often expressed in the developing brain. And even in utero, the brain may not get as much oxygen and substrate as it would in a normal circulation. Postnatally, one has all the influences, both of the heart disease itself and of the procedures that we perform that may affect how the brain is perfused. I think we now know a lot about the neurodevelopmental signature of children with congenital heart disease, which involves certain challenges in learning. And those can involve difficulty with visual motor function, executive function, sometimes attention, sometimes social adaptation and social relatedness, among others. But there is a giant amount of variation from child to child. And so we have individuals who perhaps have real difficulty in school and others who are brilliant. I try to reassure parents that we know that probably the most important influence, short of a devastating situation of a dominant gene, let's say, that affects development, or a very severe acquired problem, most important is the home environment. And study after study have shown this, and that with appropriate monitoring and intervention, we really hope we can get each child to his or her best potential.
That's great. So staying with the neurologist theme, which is no small delight to the only neurologist in the room, Zhang, I'm going to ask you the next question. Zhang, what do you think is the safest and most effective timing for initiation of antihypertensive treatment after the occurrence of a mild to moderate ischemic stroke? And what future studies should be done to improve our understanding of this issue? You led CATIS 1, CATIS 2. Will there be a CATIS 3?
Thank you. It's an important question. So in the China antihypertensive trial in acute ischemic stroke, CATIS, original CATIS study, so we compare the effect of immediate blood pressure reduction within the first 24 hours after stroke onset compared to no treatment among about 4,000 patients with acute ischemic stroke and elevated blood pressure. The primary outcome was a combination of adverse or major disability, within the first 14 days of hospital discharge. basically we found no effect on the primary outcome. But in a subgroup analysis, we do observe the potential benefit effect in patients who receive the treatment within about 24 to 48 hours. That's why we did the Curtis 2 trial compared to initiate the antihypertensive treatment, within 24 to 48 hours compared to delay treatment to 8 days. Again, we did not find any difference between the two groups. So also there are other studies that really show the same thing. There's no difference. So there's no simple answer to your question, regarding the safety and the effective timing for the initiate the treatment. So many factors such as baseline blood pressure level, the revascularization, other core treatment, and the complications should be taken into consideration. Regarding to future study, if I have the money, I will like to conduct a large-scale clinical trial, compare systolic blood pressure go less than 120, with blood pressure, systolic blood pressure go less than 140 among patients with a history of ischemic stroke. So the outcome will be stroke recurrence and cardiovascular disease. So that is really important question we really need to answer. Yeah.
Count me in, Jack. Count me in. Kathy.
Really highlights a simple question, right? But very, very difficult, difficult ways to approach it, and also the need for these multidisciplinary and kind of personalized approaches also to blood pressure. So. Can we move on to Stephen here? How do you envision the translation of recent discoveries in triglyceride metabolism into clinical practice, particularly for conditions like hypertriglyceridemia and metabolic syndrome?
Okay, I should start off by just saying, in response to the last question, that I'm really grateful to two of my UCLA colleagues, Anne Begnot and Lauren Fong, for all of our triglyceride work. I mentioned earlier that lipoprotein lipase is an intrinsically unstable enzyme. And that's physiologically important because tissues want to have very intricate and rapid control of the levels of lipoprotein lipase in capillaries. So, for example, during fasting, lipoprotein lipase is very high in the capillaries of the heart, but after refeeding, it goes down. And it's the opposite in adipose tissue. And so the way LPL is controlled is by degrading the enzyme. And in recent years, what has become apparent is that there are specific inhibitor proteins that take advantage of the instability of LPL, and they tip the scales so that there's catalytic unfolding of the structure of LPL. One of those is ANGPTL4. It works mainly in adipose tissue. ANGPTL3 and ANGPTL3-8 complex. There are these inhibitors that catalyze the unfolding of LPL in order to regulate it. And so what has happened is that many pharmaceutical companies now are engaged in developing inhibitors of these inhibitors, which function to stabilize the amounts of LPL in capillaries. And so inhibitors of ANGPTL3 are being touted at this meeting. And I think there are even better ones on the horizon. There's a complex between two of these ANGPTL proteins, ANGPTL3 and 8, that are particularly attractive, that are coming on, that will be hopefully coming to market. One of them is an antibody developed by Robert Conrad at at Eli Lilly. And I think we'll be hearing more about that, because not only does it lower triglyceride levels, it lowers LDL cholesterol, ApoB levels, while increasing HDL levels by 35 or 40%. So it seems to have a lot of good properties. So hopefully that molecule will come along, and it should help in preventing heart disease.
Thanks, Stephen. Bob, next question's for you. You've been very involved as a thought leader in developing guidelines and performance measures for valvular heart disease. A three-part question. How do you think the process of developing these documents could be improved? Number one. We have gone from just guidelines to the addition of performance measures. What is the next step in implementing evidence into practice and ensuring high quality of care?
Easy question, right?
Right.
3 minutes.
Well, I can answer that quite simply. It's a challenge. The first guidelines were published in 1998, and there was no trials. It was all pretty much consensus statements. Nothing much happened between 1998 and 2008, but that's when the partner trial began. And now the challenge, so writing the guidelines in that early period was pretty simple because nothing much changed. Now things are happening very rapidly, and the guidelines are almost out of date the date they are published because we have new trials. And so the updated 2020 guidelines now are a mess because we have no statements on tricuspid valve disease, despite the fact that we have devices that work and are approved. The mitral valve remains similarly well behind in the guideline statements. And now we have data in asymptomatic patients with aortic stenosis. So we can chew on what those data really look like. But the finding for me is that if you have severe aortic stenosis, there may not be a risk of dying, but the likelihood that you'll need a valve replacement in 5 years is so high that there's a reason to wait, And so, so the guidelines need to move faster. Katherine Otto now is the chair of the guidelines task force, and this is right in her area, and I hope that she can do what she would like to do, which is to move them more rapidly. A new trial comes along on a specific area. Let's take that specific statement out, tweak it to get it updated, and put it back in the guideline. We don't have to do the whole thing all over again. Now, the performance measures are really an issue because those sometimes drive what might be reimbursed. And so if we think that the appropriate use criteria, for example, are outdated, and they are, the last appropriate use criteria were years ago, and those are being updated now, but by the time they get published, they'll be out of date as well. So we need to move much more faster on the quality front here to keep a pace of the really rapid developments that are going on. It leaves all kinds of questions unanswered. I mean, we're moving now to younger, less symptomatic people. Okay, is that a surgical approach, or should that be a transcatheter approach? If it's a transcatheter approach, what are we going to do in the next step? So a 55-year-old with a biological valve is likely to require a second procedure, maybe a third procedure over the course of the lifetime. And so the lifetime management of our patients becomes quite complicated as well. So how do guidelines deal with that? So it's very challenging.
Thank you. Thank you both.
Okay, so our next question is for Pedro. So how were you able to successfully navigate the process of translating your clinical research work into the development of new startups and prototype generation?
Yeah, that gets at the question of really a huge problem that we have in pediatrics, and that is developing technology for kids is always going to be behind. And the main reason, at least I would say the excuse that's given, is that the market is not there. Mm-hmm. And therefore, corporations who are looking at primarily their bottom line, and in some ways very logically say, well, it's not for us to do, it's for somebody else to do it. So what we decided, this is now about 15 years ago, is that really academia needs to step up. And academia needs to make that transition between the early research into the development part. It's the development part that corporations do and they do it very well. In academia, we don't do it well. So we established a program to look at what were the biggest unmet needs. And in children, valvular heart disease is the biggest unmet need. It involves at least a third of the congenital cardiac problems we face. The same issues that you're going to face in the adults with prosthetics that don't last long enough to patients, it's our life. It's what we do. It's children undergo multiple procedures because the prosthetics include materials that deteriorate, but importantly, we don't account for growth. So what academia can do is it can look at those fundamental problems and say, okay, how are we going to solve it? And once you solve that problem, then the next step is how do you develop it in a way that it can be commercialized, that is, manufactured inexpensively, disseminated widely. And corporations can do that very well once they've had something that's been de-risked. And that's what we've taken on. We've now expanded, and we're taking on valvular heart disease for rheumatic. Because for rheumatic, we have a different problem. That is, how do we come up with a valve that we can manufacture for under $100? And we solved that problem. We have a synthetic valve that you can manufacture for under $100. Now we need somebody to take it and disseminate it. So that's the challenge. We're fortunate to be in an environment where almost 360 degrees, I look in Boston, there's an engineering school that is at the top of its game, and individuals who are really brilliant and who want to help. And so we've been able to bring those folks together and help us, and that's how we started some of the early companies to try to come up with pediatric devices. They're not going to have huge markets, but on the other hand, they're going to be profitable enough so that a larger company can take it on and say, okay, we're going to provide this for kids. And that's been our mission, and so far we've been pretty successful.
Well, congratulations, very exemplary. Deborah, last but not the least for the specific questions, what are the main challenges and opportunities to implementing self-care interventions?
Well, the main challenges is sort of refer back to what I was talking about, how, nursing care and physician care aren't well integrated. And so a lot of times nurses talk to patients about self-care, and then they go to the doctor, and the doctor doesn't talk about self-care. They say, here, do this, this is what I recommend, this is what I recommend, and assume the patient will do it. In fact, I was in a conference a couple of years ago where a really prominent heart failure physician got up and said, my patients always do what I say. And I literally almost fell out of my chair. All nurses were going, we were aghast. I don't think he noticed, but anyway. So really better integrating what physicians and nurses say, and that, again, involves really improving interdisciplinary care, multidisciplinary care, and really valuing the input of both to, all of the issues of risk reduction. They're really self-care, all of that stuff. Taking medicines even when you have something, obviously, is self-care. And all the other, factors that come into recognizing things early are self-care. And there needs to be better respect on both sides for that aspect, and better integration of the way we practice and learn and take care of patients.
Thank you, Deborah. Kathy?
Okay, so our last general question for the group is a key segment of our audience is in the early career stage, and would love to glean some of your career wisdom from all of our guests. So if you were able to give one tip to all up-and-coming cardiovascular disease researchers, what would it be and why? So we'll start with Zhang.
Yeah, we all know research is hard, right? But it also is very rewarding. So if I could give one tip to young investigators, I will say it will be persistence. Persistence is the most important character for success. Right. So do not get discouraged if your grant application is not found, your paper is rejected, or your research do not make progress. As long as you put the time in, persistent, you will be successful.
That's speaking to me too. Thank you.
Great advice. Stephen?
I would say that work on your writing skills, because as scientists, we're all fundamentally storytellers. We have to communicate our stories, and I think and you have to learn to be persuasive, and you have to learn very high quality science. And in order to get grant funding, in order to get your papers published, in order to communicate at meetings. So I think that one of the most important things, I think, is writing. So you have to work at it, you have to take it seriously, and you have to be a perfectionist. So that would be my tip.
Well said. So, Bob?
I agree with everything that's been said, and probably what will follow after me. The big thing for me is, okay, get involved with the American Heart Association, because that's obvious, but a meeting like this allows you to broaden your horizons. We tell people to be focused. Focus on your research. The problem is if you focus too much, you can have tunnel vision. You need to use your peripheral vision, and a meeting like the American Heart Association, where you're seeing all these other new ideas, other potential collaborators. So use your peripheral vision as well as the constant demand to focus.
Great advice. Pedro?
Just speaking from my own personal experience, get involved with a high-quality team early on. When I got my first residency in cardiothoracic surgery, I arrived there and they said, well, we gave away your position, unfortunately, but we can send you to the lab for a couple of years for you to do some work and then come into the clinical. And it was the best thing that ever happened to me, because they sent me to a place called the Banting Institute, which was a cauldron of research with individuals who were not only expert, but they're enthusiastic, and they taught you a lot. And that, for me, was formative. I think if you can find that place, immerse yourself in it, and just live that world, it'll serve you for the rest of your career.
Great advice. Deborah?
I loved the persist idea. I really always tell everyone they must persevere. You have to learn how to write well, you have to persevere, you have to pick up new things by reading, and the only way to get a grant is to persevere, and get people to help you, have a good team, have great mentors. It's way funner if you are working with other people, much more fun and much more incredible explosion of ideas. That was more than one thing, but.
As we've emphasized, team science really is a key. We'll end with Jane.
My idea would be, it's very similar to Bob's and Pedro's, which is that I advise early career people to be daring and to reach outside their comfort zone to new disciplines, so that they can bring a new discipline that's great into our small field of rare diseases, and kind of do something really new and pioneering.
Thank you all. Well, this exceeded my already lofty expectations, and I hope it did for you as well. We'd like to congratulate once again all of our AHA 2024 distinguished scientists on receiving this honor, and thank them for taking the time and the effort to share their insights and their experiences with us. To our dear audience, if you've enjoyed this conversation, please subscribe to AHA with JAHA on Apple Podcasts or Spotify, and look out for our next episode. And if you aren't following us already, please do on social media. You'll find us on X, formerly known as Twitter, at JAHA_AHA, as well as on Facebook and on LinkedIn as JAHA, Journal of the American Heart Association. Thank you all for tuning in.